Okay, there we go. For those online, the take home from what I've said so far is look in the chat for your CME credit, and we're pleased to welcome Dr. Allison Betof Warner. So she also serves as the director of the Melanoma Medical Oncology Program and director of Solid Tumor Cellular Therapy, and also co-director of the Pigmented Lesion Melanoma Program at Stanford. She has a lot of leadership positions there. She has been a pioneer in the use of TIL therapy, use of commercial TIL therapy or tumor-infiltrating lymphocyte therapy, which is expected to become a standard of care for immunotherapy refractory melanoma. At Stanford University, she is the leader of the Melanoma and Cutaneous Oncology Clinical Research Group, which focuses on tumor response to immunotherapy. And she has also been the principal investigator of multiple clinical trials focusing on immunotherapy refractory melanoma. She's internationally recognized for her expertise, particularly in central nervous system metastases and the use of cellular novel therapies. She collaborates with investigators around the world in multiple different disciplines, from neurosurgery or from surgery to medical oncology and radiation oncology and pathology. She has received numerous awards, lots of funding to allow her to do the amazing work she's done, and is a member of many organizations, including ASCO and the Melanoma Research Foundation. She has published her research in multiple peer-reviewed journals, has been the editorial boards and a grant reviewer for multiple organizations, including the Melanoma Research Foundation, and has authored numerous case reports and book chapters. She's contributed a lot to our understanding about melanoma and how it responds or fails to respond to immunotherapy and how we can overcome that. We are thrilled to have her here today. We're thrilled to hear her talk about TIL therapy, and I will not delay that any longer. So please join me in welcoming Dr. Allison Betof Warner.
All right. It is a pleasure to be with you. Thank you all for coming. Thank you for the invitation. And I'm excited to dive in and talk about TIL therapy and solid tumor cell therapy in general. And this talk is entitled, "We Have Reached the Tip of the Iceberg." And I hope that I will convince you of that this is truly just the beginning of this journey. These are my disclosures. And let me just start by saying we have made tremendous progress in the last decade, 15 or so years, with the implementation of targeted therapy as well as immune checkpoint inhibitors. And many times we hear how far we've come, and I think that is very, very true and shouldn't be downplayed. What I'm going to emphasize today is we still have a very long way to go. For many patients, response rates remain unacceptably low, and durability, particularly to targeted therapy, remains unacceptably short for our patients. And our clinic are full of patients that are progressing on all of our new modern standard therapies. And so we need to do better. And we'll start by talking about melanoma as an example. And most importantly, because I'm a melanoma doctor, it's my favorite thing to talk about. So I'm going to subject you to some of that today. But also because melanoma tends to be a jumping off point. Most of our new modern immunotherapy strategies start in melanoma and then come to many other solid tumors, as we've seen. So if we look back only a decade and a half, so 2010, right, pre-approval of ipilimumab for melanoma, this was the survival curve. And these survival curves for melanoma didn't change for about 3 decades. Median overall survival for this disease was somewhere between 6 and 9 months. And we were using the same chemotherapy for many, many decades, dacarbazine, temozolomide, and those overall survival curves just didn't budge. As we all know, with the implementation of ipilimumab and then nivolumab and pembrolizumab, followed by combination ipilimumab plus nivolumab, the overall survival bar have shifted markedly for this tumor or for this disease. And we now have a median overall survival that went from something in the range of 6 months to 72.1 months. This is from the pivotal Checkmate 067 trial, the phase 3 randomized trial of ipilimumab plus nivolumab. And that is amazing and incredible progress. And yet, what about all of these patients? All of the patients who do not benefit from this combination therapy and are treated with this frontline therapy in our clinics and then go on to need alternative therapies. And that to me is really where I see the potential for adoptive cell therapy. And many of us are very familiar with CAR T-cell therapy, and some of us familiar with TCR T-cell therapy, so engineered TCR T-cells. What I'm going to focus the first part of my talk on today is TIL cell therapy, which may be newer to some of you. But in CAR T-cell and engineered TCR T-cell, patients undergo leukapheresis. We take naive T-cells, we engineer on a receptor when we know what target we are going after, and then administer those engineered cells to a patient. Often in solid tumors, that's not an option because we don't know what target to go after, or we have not been able to design a receptor that hits that target well. And so TIL cell therapy comes at this differently and says, what if we take out a piece of tumor? When we do that, we find a bunch of T cells that were able to identify that tumor. And we expand those T cells in a polyclonal fashion, a target agnostic fashion, and then give those back in bulk to a patient. That's the general principle here. This is not a new concept. You heard Crystal right before we started talking about the 50th anniversary of Dr. Rosenberg's group. This research has been going on for many, many years. And in fact, the first TIL trials were in the late 1980s at the National Cancer Institute. And you can see here, there was early success with this approach. So why did it take us 40+ years to get this into the clinic? So this is, as I like to say, an older concept made new again by some considerable advances in technology. The first is the ability to reliably produce TIL from patients who undergo surgery. So in the older days at the NCI, many patients would undergo surgery, and unfortunately, the TILs just would not expand. We wouldn't get a viable number to infuse back into patients. And so patients would wait this period of time and then ultimately not have a treatment. And that has improved markedly. The ability to cryopreserve a TIL product. So take out these tumors, expand the cells, freeze them, and ship them, which allows for central manufacturing and for patients to be treated closer to home at centers of excellence. A shorter turnaround time, I'm still going to argue that this is far too long for our patients. Current manufacturing time is about 5 weeks, but this is considerably better than it used to be. And the ability to take a patient and produce TIL in a reliable fashion in a reasonable period of time has been a considerable step forward. And then data for efficacy in checkpoint refractory patients is really what got this across the finish line to FDA approval. So an overview of the process, I gave you a little bit of information here, but essentially patients undergo a surgery. We take out somewhere between 1.5 centimeters cubed and 4 centimeters of tumor, and then ship that off for commercial product to a company who does the isolation from tumor cells and expansion. So this is isolation and expansion in an IL-2 based solution, growth of those TILs, and then further expansion, and then cryopreservation of the product. So we get frozen bags of cells shipped back to our center. At that point, patients undergo a preparative lymphodepletion regimen that is still good old-fashioned Cytoxan and fludarabine. It is very high-dose Cy/Flu, so for those who come from the CAR T-cell world, this is much higher dose than we are used to for TIL cell therapy, and that is an area that we are looking to improve upon. Patients get 5 days of high-dose chemotherapy, followed by TIL infusion, and then up to 6 doses of high-dose IL-2. And that is the toughest part of this regimen for patients. We will talk about that as we move through this talk. Still necessary as far as we are aware, because there is not a clear co-stimulatory signal on these T cells, that IL-2 is still needed as part of this process. This is all done in the hospital. Lymphodepletion is sometimes done outpatient, but TIL infusion, IL-2, patients are in the hospital somewhere 10 days to 2 weeks, and then recovery and discharge. So we'll start with the data for melanoma. And the FDA approval of this agent was based on the C-144-01 trial, and you can see the trial design here. Essentially, there are 2 main cohorts to focus on, but they are both, in general, the same patients. These are advanced melanoma patients with unresectable melanoma or metastatic melanoma who had at least one prior line of therapy that was a PD-1 containing regimen. So that could be single agent PD-1, Nivo-Rela, Ipi-Nivo. And if patients had a BRAF mutation, they were required to have also progressed on a BRAF containing regimen. Then patients went into originally cohort 2, then cohort 4, which were essentially similar patients. It works out to be 153 patients total. And the key primary endpoint here is objective response rate. So if we look at the pooled cohort 2 plus 4 data, again, these are very similar patients. We get 153 patients with PD-1 refractory melanoma. These are very heavily pretreated patients, so a median prior number of lines of therapy was 3. I will tell you that there were many patients here that were on 6th, 7th, 8th, 9th, 10th line therapy, guilty as charged. It was very challenging. There was a lot of competition for spots on these trials. Patients were waiting a long time to get access to this drug. And so these were very, very heavily pretreated patients. And what we see here is an objective response rate, so complete responses plus partial responses of 31.4%. But I think really importantly, a disease control rate of nearly 78%. So when you include stable disease, which is a win for patients with refractory disease that have no standard treatment options, we actually get 78% disease control rate. And what's really promising about this approach is this is a one-time treatment. And for those who live in the CAR T world and hematologic malignancies, that is not a new idea. But for those of us with solid tumors who are used to treating our patients every 2 weeks or 4 weeks indefinitely, the concept of a one-time treatment with a durable response rate is truly, game-changing for our patients. The median duration of response in this trial was not reached. And I think that is exceptionally important to recognize that 42% of the patients who responded in this trial were still off treatment at the 2-year mark. And so I always tell my patients, I talk about this every single day in my clinic. I tell patients that this is a really big hammer for a really big nail, right? This is a tough problem. This is a tough treatment. But the chance to get a one-time treatment response with durable responses, I think, can't be overstated. Median overall survival in this trial was 13.9 months. As I said, this is a tough treatment, and I think that is important to recognize. But if you look here, what we can see is that most of the toxicity is actually concentrated in those first 2 weeks from cells. So this toxicity is basically hematologic toxicity and associated challenges of lymphodepletion. So neutropenia, thrombocytopenia, febrile neutropenia, infections, all expected complications of lymphodepleting chemotherapy. And then known toxicity from IL-2. So fevers, chills, rigors, occasional hypotension, and renal dysfunction, all expected toxicities with IL-2. The median number of doses in this trial was of IL-2 was 6. What we actually learned from this trial, which was presented at ESMO IO in 2022, was that the median number of doses of IL-2 actually does not, the number of doses of IL-2 does not correlate with response if we stop for toxicity. So I always think of this like checkpoint blockade, right? When patients hit intolerable toxicity with checkpoint blockade, you've gotten enough immune activation, you stop, right? And it turns out that that is actually true with TILs with IL-2 as well. And so whereas in this trial, before we had this information, we pushed these patients really hard to get all 6 doses of IL-2 because we thought this was our one shot on goal. As it turns out, we don't need to do that. And in fact, this treatment has become much more tolerable, and many patients are getting somewhere in the range of 3, 4, maybe 5 doses of IL-2, but most are not getting all 6 doses. These are not the only data for TILs. So many of you may have seen this paper. This was the phase 3 randomized trial from John Hannon's group of TIL. These were homegrown TIL at the Netherlands Cancer Institute, but they look quite similar. The process is quite similar to the Iovance TIL product, other than it is not frozen. So this is a fresh TIL product and patients are treated on site. But this was a randomized phase 3 trial. of patients, nearly all patients, though not all, had been PD-1 progressors, but 1 or 0 prior lines of therapy. As I said, about 80+% of those patients had progressed on prior PD-1. Those patients were randomized 1-to-1, 168 patients randomized 1-to-1 to either TIL or ipilimumab. Excuse me. Now, we all wish that that control arm had been ipilimumab plus nivolumab. That would have been much more similar to our standard of care here in the US for PD-1 progressing patients. That is not the standard of care in Europe where this trial was done. And those patients and those investigators did not have access to ipilimumab plus nivolumab in this setting. And so while this trial has received a lot of criticism for not doing ipi plus nivo as a comparator arm, they simply couldn't where this trial was done. That being said, if we compare these arms, so this is progression-free survival, TIL shown in red, ipilimumab shown in black. As my old PhD mentor used to say, you don't need stats. The curves speak for themselves, right? Median progression-free survival for ipilimumab, for TIL was 7.2 months versus 3.1 months for ipilimumab, with an objective response rate of 49% versus 21%. And I will tell you, and trainees in the room, cover your ears because you're not supposed to do cross-trial comparisons. So I'm going to tell you that you're not supposed to do that, but we all do it anyway. If we think about ipilimumab plus nivolumab objective response rates in the PD-1 refractory setting, we're talking about max 29% across all trials. 49% blows that out of the water. And if we look at a complete response rate of 20%, that is in fact better than we see to ipilimumab plus nivolumab in the frontline setting. So I think it's hard to argue with this treatment as a very viable treatment option for our patients. Certainly, again, tough treatment, 100% grade 3 or above adverse events. All of those, as you can see, were hematologic toxicities as well as toxicity associated with the IL-2, just as we saw in the C-144-01 trial. Dr. Hannon and his colleagues did us all a gigantic favor in this trial and looked at 6 months at health-related quality of life. So 6 months post-treatment, right? Again, we know this is a tough month or 2 weeks of treatment, but what do these patients look like 6 months later? And you can see when we compare the TIL to the ipilimumab group, you can see statistically significant improvements in quality of life, physical functioning, emotional functioning, and a variety of symptoms at the bottom. And so it is important to remember that while this is a tough treatment, it is a one-time treatment, and checkpoint blockade is not without its own significant and long-term toxicities and effects on patient quality of life. So all of that being said, February 16th, this all became a reality, and FDA approved lifileucel as the first ever cellular therapy for any solid tumor. This was our team less than 1 business day later doing the first surgical harvest in the world. So FDA approved this on Friday afternoon at about, I would say, 2 p.m. West Coast time. We immediately jumped into action. We had already had about 4 patients waiting, consented our first patient, and Monday was a national holiday. At 7 a.m. on Tuesday, we had the first patient in the world in the OR undergoing surgical resection for lifileucel. And you can see that picture on the far right was April 4th, our team infusing the first commercial patient in the world with lifileucel. Whoops, sorry, wrong direction. We have worked very hard to help others implement this therapy as well. I think, as you can see, the enthusiasm for doing this, but also the challenges with doing this. And so this is an expert consensus white paper that was, I helped to lead, that came out of the TIL working group that is essentially a nuts to bolts, how do we implement this therapy? So if any of you are old enough to remember rounding on IL-2 patients, right? We all walked around with checklists and what do we need to do? Do they meet criteria for the next dose of IL-2? All of that is in this paper essentially in a different context for how do we make treatment decisions. How do we clear the next dose of IL-2, which is different in the context of TIL than it was as IL-2 as a therapy? How do we set up our units? What are the surgical considerations, and many other pieces. So we hope that this is helpful. We have heard from many centers that they are sort of keeping this on the floors where they are treating their patients. It's certainly living on our floors where we are treating our patients. So all of that said, I think this is not the culmination of a journey, but instead the very, very tip of what I hope is a very big iceberg, bringing cellular therapy to solid tumor patients. So I'm going to talk a little bit about some of my work in trying to push this forward beyond what is now an FDA-approved product, to bring this to more patients. So one of the challenges that we know is that up to 70% of our patients with advanced melanoma will get disease in the brain. As of right now, TIL is not recommended to be used for patients with active brain metastasis due to the risk of hemorrhage and seizure, intracranial edema, and other issues. But this is a huge problem. We are turning away patients left and right at our center because of active brain metastases, and they just can't get a period of stability where we can safely treat them. And so we started to ask the question, well, can we adapt this regimen to actually treat patients with TIL in the brain? So what do we know? So at the NCI, there were patients treated over the years that had brain metastases. These were typically patients who had undergone harvest and then while waiting for their cells to be produced, developed a new brain met and were felt to be safe and stable enough to undergo treatment. This was 17 patients. This was not a prospectively done clinical trial. This was a conglomeration of clinical experience over many years. But what they saw in these 17 patients were complete responses in the brain in a variety of patients, many lasting up to 43 months with an estimated 2-year overall survival of 40%. But I think really important to recognize the risk of intracranial hemorrhage. So melanoma brain mets, for any of you who treat melanoma in the room, they love to bleed. They love to bleed without lymphodepletion. And then we lymphodeplete patients and they're thrombocytopenic for weeks. The risk is real here. This was seen at the NCI. This was seen in the clinical trials, in this trial and others. Additionally, there was a case report presented at AACR a few years back now of a 16-year-old man also treated with TIL for BRAF mutated melanoma. He had had prior ipilimumab as well as dabrafenib, and he had a successful treatment with TIL with a durable complete response at 7+ years post-therapy. But important to note that his course was complicated by seizures, which were actually quite dangerous seizures during his treatment, likely related to IL-2 lowering the seizure threshold, brain mets lowering the seizure threshold, and potentially intracranial edema as well from IL-2. So this isn't something that we should just think, oh, we should start throwing FDA-approved commercial TIL at our patients without planning for that. So we designed a pilot trial of lifileucel for patients with melanoma brain metastasis with a few modifications to this protocol. So we adjusted the dose of lymphodepletion pretty considerably to try to minimize the thrombocytopenic period for patients. We transfused them up to platelets of 50,000, which in some patients required continuous platelet drips for several weeks, which was what led to the modification of the lymphodepletion regimen. All patients were on seizure prophylaxis, and patients were also getting daily neuro-oncology consults and neurochecks Q8. This is an investigator-initiated trial that I started when I was at Memorial Sloan Kettering, was taken over by my colleague, Dr. Alex Shustari, and actually very recently finished accrual. And one of the things that we felt strongly about was not only figuring out a way to treat these patients, but also learning from these patients scientifically. So all of these patients had multiple blood draws, multiple lumbar punctures. We have CSF on all of these patients. We have tumor biopsies pre and post on all of these patients. This trial finished accrual, and I'm excited to tell you that it will be presented for the first time at SMR in just a few months. And we are excited to potentially expand this trial and start thinking about efficacy beyond just a safety signal for these patients. We also have pretty extensive correlative analyses that are underway. Those will not be presented yet later this year, but stay tuned for that. Really excited not only to look at the tumor outcomes, which we are obviously doing for commercial TIL as well, but particularly to look at the CSF and think about how we can modify this protocol for patients with brain metastases, one, to increase safety, as well as to potentially really target the CNS in a more systematic way. Additionally, as any of you who work in melanoma are aware, uveal melanoma is its own beast, does not necessarily respond to checkpoint blockade in the same way, and is not included in the FDA approval for lifileucel. And so Dr. Shustari and I also initiated an investigator-initiated clinical trial of lifileucel for uveal melanoma that literally finished accrual in the last month or two, and hopefully will read out in early 2025. What about beyond melanoma? So we now have data for TILs in many other types of cancer, and I think this is one of the really exciting things to see, just as we've seen with checkpoint blockade, advances in melanoma starting to carry over into many other types of solid tumors. So these were data presented by my friend and colleague Adam Schoenfeld at World Lung in 2022, but efficacy of TILs in checkpoint naive non-small cell lung cancer, and very small number of patients, so full caveat there. But you can see tumor shrinkage in these difficult to treat patients, right? So these are patients in general who are not expected to respond to checkpoint blockade, right? PD-L1 negative patients, oncogene-driven lung cancers, things that don't typically respond to classical immunotherapy. And we see 50% of the patients, 4 out of the 8 with PD-L1 negative disease responded to TILs. There was a response in an EGFR mutated lung cancer post-TKI. So promising early signals. Similarly, Adam published a beautiful paper in Cancer Discovery earlier this year, which was the Iovance COM202 lung cohort. So these were checkpoint experienced patients, checkpoint refractory patients, and you can see the trial design here. This was one arm of the COM202 trial. So surgery, 22-day manufacturing, patients underwent lymphodepletion at the standard regimen, TIL infusion, IL-2, and this looks quite similar to the melanoma cohort. There was a follow-up to this that used checkpoint blockade in addition to TILs. That is not what was presented in this paper, but we will see those data coming as well. And you can see this certainly is not as exciting. The curves don't look nearly as pretty as they look for melanoma, but there absolutely are responses, including deep responses and one CR in these patients. And we still see, when we do see this, we are seeing durability. And so while this unmodified TIL in these checkpoint refractory patients may not be the end-all and be-all for non-small cell lung cancer, there is certainly a hint of efficacy here and potential for us to really jump off and improve upon this. Also data, very small numbers of patients, but exciting proof of concept in in head and neck squamous cell carcinoma, this in combination with pembrolizumab, as well as in cervical cancer. And we're starting to see these trials start to come in like wildfire, right? Lung cancer, head and neck cancer, GYN malignancies, and growing and growing. And I will highlight some of those trials that are to come. So where are we going, right? Bulk unmodified TIL, I like to say, is ipilimumab, right? And I hope in 5 years, none of us are giving bulk unmodified TIL because we have something better. But we didn't get to PD-1 without going through ipilimumab, and we're not going to get to something better without giving patients bulk unmodified TIL and learning from them. So where are we trying to go? So I highlighted some of those trials starting to combine checkpoint blockade with TILs. And while that may be a good approach, and we certainly are doing those trials, it defeats the purpose of a one and done treatment to then have to keep patients on checkpoint blockade long term. Also, many of these patients have either already had checkpoint blockade and had all of the associated toxicities with checkpoint blockade, or will get all of the associated toxicities with checkpoint blockade. So trying to avoid that would be really advantageous for us. So this is one strategy. So Iovance's second generation product uses TALEN deletion to delete the PD-1 gene. So instead of giving patients PD-1 blockade, let's just knock it out and in the TILs. and see if that is effective. So this is a phase 1/2 open label study of PD-1 deleted TIL. This is Iovance 4001 in patients with metastatic melanoma, and then an expansion cohort planned in non-small cell lung cancer. And this is an ongoing accruing trial. LYL845 takes a slightly different approach. So if we look at standard TIL expansion, we know that we get bulk TIL, many of which are exhausted or nearly exhausted, some of which are terminally exhausted. So we infuse these T cells into patients that are never going to work. And so this uses a slightly different approach with the goal of modifying the expansion media to try to create a more stem-like phenotype for the infused cells and more cytotoxic cells. It preserves the polyclonal nature of the T cells. And one of the advantages to this approach is we have seen good expansion across what is typically considered cold tumors, things like colorectal cancer. And so this study is open and accruing. I'm treating patients on this study at Stanford. I am gonna snooze that so you guys can actually see this. So this is in dose escalation at the moment. And then a planned expansion to melanoma, non-small cell lung cancer, and for the first time, colorectal cancer, which I think is really exciting to potentially bring TILs to the GI population. And perhaps what I think is the most exciting TIL trial going on right now, one of the hardest parts of this regimen, as I mentioned earlier, is the IL-2. And all of us are desperate to get rid of the IL-2 because this limits the number of patients that we can treat. This limits, patients to having excellent performance status, being younger, excellent cardiopulmonary function, no brain mets, et cetera, et cetera. So if we could think of a way to get rid of the IL-2 and still stimulate these TILs, this potentially expands this to a much wider patient population. And OBX115 is an attempt to do that. So these cells are engineered. Patients undergo a surgery or multiple core biopsies, which is now being done in this trial. Cells are then engineered to express a regulatable IL-15. So the cells constitutively express IL-15, but it degrades at baseline. When you give the patient acetazolamide, that IL-15 stabilizes, binds to the membrane, and activates through the IL-2 receptor. So this is essentially an on-off switch for the cytokine. This trial is open. It is accruing. We are treating patients at Stanford. This is the trial schematic. You can see the manufacturing time is a bit longer. As you can imagine, it is about 6 to 7 weeks right now, though hope to be improved in the foreseeable future. Then patients undergo lymphodepletion. This regimen is using a lower dose lymphodepletion, as then followed by cell infusion and no need for IL-2. You just give the patient acetazolamide, turn that on, and if and when they start to have toxicity, you can also take that off. There's a planned treatment for 9 days with acetazolamide, but it can be stopped earlier if needed for toxicity. So first in human data were presented this year at ASCO by Rhoda Amaria. And this was 9 patients in the efficacy cohort. You can see an objective response rate of 44%, including 2 patients who had complete responses to this IL-2-less regimen. Really importantly, no dose-limiting toxicities seen in any of these patients, no significant cytokine release syndrome, and no ICANS. So we're really excited about this trial. This trial has now expanded to allow patients with previously treated brain mets as well as non-small cell lung cancer. We have a wait list of patients waiting for spots on this trial. I think patients are very excited about it, as is the TIL community. So in addition to these trials, I think a huge part of what I am doing is trying to figure out how this works and how we can take this back to the drawing board and really engineer better cell therapies, right? I think OBX115 is one attempt to get there. I know many in the room are working on this as well. So this is our platform to do this, and this is a collaboration with Dr. Zena Good, who was a postdoc in Crystal Makel's group and is coming on faculty in the very foreseeable future. She's a computational biologist. But essentially, we take every single patient that we treat with TILs. We take a piece of the tumor that goes into making their TIL. We sample their infusion product. We have serial biopsies of both tumor, blood, and when we can get it, any other tissues, so skin, CSF, anything else we can get our hands on from a patient. We are doing TCR-seq, single-cell RNA sequencing, and spatial proteomics on every single, spatial transcriptomics on every single one of these patients at about 6 different time points. We've received really generous funding from multiple sources to do this on every single standard of care TIL patient. And then Zena's really developed this very interesting technology, both to fate map T cells to be able to trace them back and lineage trace them, but as well as created sort of AI large language learning models to input all of both the single cell sequencing and the spatial data into a augmented platform to be able to understand patterns of resistance in a way that I don't think any of us have really been able to do in the past. And so we're really excited. We have banked about 20 patients or so far and are knee deep in the analysis of this as we speak, and hope to be able to share some data with you in the foreseeable future. So I'm going to take just the last couple minutes and talk briefly about things beyond TILs, right? I think TILs are certainly particularly exciting, but we now know TCRs, but CARs, which have had so much promise for hematologic malignancies, I think we're on the very edge of starting to see them potentially come to solid tumors as well. So we'll start with engineered TCR cells. So one of the challenges here, as I mentioned earlier, is that we need to know the target that we're going after. And for many solid tumors, we do not have good common shared antigens that have enough differentiation from normal tissue that we can actually target them. But when we do have a good target, we can engineer and virally transduce naive T cells to express an engineered TCR. One of the advantages here is that there is no thymic selection of these cells. So this allows for target selection beyond cancer-specific neoantigens, which is a huge advantage. And we can go after things like driver mutations, antigens arising from virally encoded genes, which opens up things like head and neck cancer with, cervical cancer with typically virally driven cancers. Cancer germline antigens, of course, and melanoma differentiation antigens. One of the advantages of TCRs is that they allow for targeting of intracellular proteins because these antigens are displayed on MHC. And many of our targets are intracellular proteins, which has been a limit of CAR T cell technology. The flip side here is that there is high potential for on-target off-tumor toxicity, and we need to be exceptionally careful with our target selection, as well as think really intelligently about things like on-off switches or logic gating and how to turn these cells on and off potentially in different target tissues. And as we saw from early attempts at TCR trials in melanoma, there's real danger here, right? We went after melanoma differentiation antigens in the early days, caused blindness, caused deafness in patients because of melanocyte expression in many of the eyes, ears, and other normal tissues. One of the real limitations to TCR T cells is that because these antigens are required to be displayed by MHC, you have to have HLA genotype matching for the TCR, and that really limits the patient population. That being said, August 2nd, hot off the press, we had approval of the first ever TCR T cell for solid tumor, afami-cel, which was very newly approved for synovial sarcoma. This is a product made by a company called Adaptimmune. And you can see this was the Spearhead-1 trial led by Sandra D'Angelo at Memorial Sloan Kettering. I had the pleasure of treating patients on this trial when I was there. This included patients, this shown in stars here, are myxoid round cell sarcoma, but the vast majority of patients were synovial sarcoma, and in those patients, 17 out of 44 patients had complete responses with an objective response rate of 39%. Prior to this approval, just a few weeks ago, there were 0 drugs approved for synovial sarcoma. So this is a huge step forward for this field. Median time to response only 5 weeks, and the median duration of response was 50.3 weeks. So really, a really exciting step forward. That being said, this is a very rare disease and then limited to HLA-A2 type. And so this will be a small number of patients, but I think a really pivotal moment for our field to now have TCR-T technology. This is the overall survival curves, and you can see the overall population with an overall survival of median overall survival of 16.9 months, but the responders median overall survival not reached yet from Spearhead 1. We do have a really exciting, I can't skip opportunities to highlight exciting things in melanoma, but we have an exciting PRAME targeting TCR trial that is soon to open. We saw data presented by Martin Wermke last year at Society for Melanoma Research. This was from the phase 1 of IMA203. This is a TCR-T targeting PRAME in PD-1 refractory metastatic melanoma. You can see small number of patients, but 12 patients, 6 responders in those patients with confirmed objective responses. And you can see beautiful durability in these patients with a median duration of response not reached and a median follow-up of 14.4 months. So the registrational phase 2/3 trial is about to open. We're in the regulatory process for opening this trial, and I think particularly excited about this. This trial uses lower dose lymphodepletion and low dose IL-2, and so potentially much more tolerable for patients than a standard TIL regimen. I will briefly mention our forays into CAR T cells and solid tumors. Again, you have to know your target, but when you do, this is obviously quite potent technology. One of the limitations, as I mentioned earlier, is that we can only target extracellular antigens with CAR T cells, at least at this time. Still high potential for on-target off-tumor toxicity, so target selection remains very important. But one of the key advantages is no HLA restriction, and so potentially opening this up to a lot more patients. So I will talk just briefly about a trial that we have opening. This was initially led by Anusha Kalbasi, who came to Stanford about 2.5 years ago now from Tony Rebus's group at UCLA. He's a radiation oncologist. This is an IL-13 receptor alpha targeting CAR for melanoma. And so this is the validation of this as a target, but you can see high expression in melanoma cells and quite low in normal tissues, except the testis and pituitary glands, which I will talk about. But good differentiation. You can use an IHC scan, which is nice. We can test patients and screen patients pretty easily and quickly for IL-13 receptor alpha. This is the normal tissue expression, again, high in testis and pituitary, but otherwise very little normal tissue expression, so really an optimal target here. This CAR is a IL-13 receptor alpha cytokine CAR that was initially delivered into the CNS for GBM by Christina Brown, and this is a second generation cytokine CAR. Good efficacy in this trial and good safety in this trial as well. And so Anusha decided that given the expression in melanoma as well, we should do the first in human systemic delivery of this CAR. And Anusha started this when he was at UCLA in collaboration with City of Hope. There were some toxicity issues in the first dose level here, and this was this dose level 1 dose exploration. There were 2 patients, unfortunately, who died out of 5 in that first dose level. 1 died of grade 5 cytokine release syndrome, the other of sepsis, probably related to the lymphodepletion. But as a result of that, we have taken this down to a lower dose level with lower dose lymphodepletion. That is open and accruing at UCLA, and we are expanding that to Stanford, where I will be the PI of that trial. But what we do see, and I think early promise, is good CAR T cell expression. And I don't have time to show you this, but we are also seeing good on-target targeting of that CAR. And so early days for this trial and more to come, but I think a hint that we will start to see much more of this to come. So I want to spend just maybe 1 minute talking about some of the practical considerations as someone who lives in the world of trying to bring cellular therapy to solid tumor patients every single day. So part of my role at Stanford is I run the melanoma program. The other half of my role is I'm the director of solid tumor cell therapy. And I think a lot about how do we implement this treatment, not just for small diseases like melanoma and synovial sarcoma, but when this starts to come to lung cancer and colorectal cancer and breast cancer. And how do we treat these patients? How do we treat them safely? How do we use the expertise of our colleagues in BMT and cell therapy, but also the disease-specific expertise that we have all gained by treating solid tumor patients in each unique disease group? And I think that's a really important piece, right? There are many institutions that think about, giving these patients and sort of handing them off to cell therapy, and then, at the end of 30, 60, 90 days, we hand them back. And I think that's a real loss for our patients to not be treated by their disease-specific doctors and not be monitored during that period of time by people very familiar with the unique aspects of their disease. For example, we talked about melanoma and brain metastasis, and that became a real issue in TIL patients. And so, I think there's real need for complex care coordination between BMT, cell therapy, inpatient teams, outpatient longitudinal doctors, in our case of TIL surgery, pathology implementation, right? Bringing all of these teams together to optimize care for our patients. Patient identification and selection, identifying these patients early when they are well enough to get lymphodepletion, cells, and in many cases IL-2, before they are so sick that they can't do this treatment or they can't wait for the manufacturing period. Working on manufacturing time certainly is a challenge, and we know that solid tumors can progress very quickly. So waiting 5, 7, 9 weeks for manufacturing, depending on the product, is really a challenge for many of our solid tumor patients. Thinking about bridging therapy. So how do we keep our patients stable and well during that manufacturing period of time? And can we move this up? Can we harvest tumors sooner so that when patients progress on standard frontline therapy, we can immediately turn around and treat them with cells, rather than waiting, harvesting after they're already progressing, and then waiting another 5 to 9 weeks, which for many patients, unfortunately, is just too long. And we have already lost many patients just waiting during that manufacturing time. The need for inpatient hospitalization is a real challenge here, right? Again, when we have small diseases like melanoma or synovial sarcoma, that's not that many inpatient beds. But if we start routinely treating patients with lung cancer, colorectal cancer, breast cancer, and others with cell therapy and require multiple week hospitalizations, I don't know about you, and maybe you have that type of space in Georgia. We sure as heck do not have it, in our hospital in California. Where do we put all these patients? And how do we think about, safely transitioning them to outpatient sooner, and or during the lymphodepletion process, to really be able to treat a maximal number of patients? Care coordination I talked about, and certainly, not to be minimized, but the cost of this treatment is overwhelming. And when we start thinking about treating large number of patients with cellular therapy that is, upwards of $1 to $2 million per patient, right? The cost and the challenge on the healthcare system is going to be really important here. And so thinking about cost containment models, but also modeling, what is a one-time treatment? And maybe that ultimately is actually cost effective if we do a one-time treatment for patients early in their course of therapy, rather than keeping them on indefinite, still expensive infusions, periodically, weekly for many years. So just things I think to think about as this field is growing and expanding. With that, I think I will just say the era of solid tumor cell therapy is finally here. Many of us have been waiting for this day for many years. Unmodified TILs have set the new bar for treatment of PD-1 refractory melanoma. Toxicity is real, but short-lived. Management is rapidly improving, and long-term quality of life is excellent for responders. Cell therapy offers a one-time treatment option for patients that was previously just not even a glimmer in our eye for solid tumors. And adoptive cell therapy with modified TILs, TCR T cells, and CAR T cells is in much earlier stages, but are really exciting as potential alternative strategy. I'd be remiss giving a talk this week if I didn't just mention and just take a second to honor the passing of Jeff Weber over the weekend. Jeff was a pioneer in melanoma and immunotherapy, fellow of the AACR, ASCO, and SITC, and helped to develop IL-2 as a treatment, checkpoint blockade as a treatment, and most recently was leading the mRNA vaccine trials for melanoma. I had the pleasure of sharing many patients with him when I lived in New York, and truly, I think, just set the bar for many of us as a physician scientist in this field. And so Jeff passed away on Sunday, and I just wanted to take a second to honor him. And with that, I will say thank you to my collaborators at Stanford, back at MSK, and Jed and Paul, who moved from MSK to Cornell, all of my funding agencies, and I'm happy to take any questions that you have.
Spectacular talk, really inspiring, and I agree. I think it's super exciting where we're at now with cell therapy for solid tumors. My question is, maybe something you guys are already working on or thought of, but with the lymphodepletion and TIL therapy, now that it's mainstream and the toxicities associated with infection, are you paying attention or tracking data on antibiotic use and how that might impact?
We are. We definitely are. I don't have any data yet. It is early days, but we are, and it's something we've been talking about, even antibiotic use at the time of surgery, right? I've always worried about this, right? We give a huge whopping dose of antibiotics right before we make our first incision and before we take out the TIL, right? And so, yes, this is something we're paying attention to. I mean, I think Jen Wargo's data and others on antibiotic, impacts on checkpoint blockade. I think we will learn a lot in the coming days, weeks, months, and years as more patients are treated with standard of care TILs and TCRs, et cetera. But yes, those are data we're collecting, probably too early to know anything about the effects.
Very inspiring. I was wondering your thoughts. I've heard throughout your talk the theme of lowering the lymphodepletion, which is great. I'm wondering your thoughts on finding ways so you don't have to lymphodeplete at all, post-conditioning and unique new ways, and are you thinking about that?
Yeah, for sure. We are thinking about it. I mean, I think one of the things that we know from the CAR world, right, is you need really effective cells. And if you have really effective cells, you can probably use less lymphodepletion. I think one of the challenges with TILs is that we have, bulk polyclonal cells, many of which won't do anything, a very small percentage of which are probably your effector cells. My hope is that by engineering better cells, that helps us lower the dose. But I also think there are many tumor microenvironment targeting approaches that we can think about as we are getting smarter, right? That, hopefully negate the need to give just chemo, right? Like, what if we finally found the holy grail of the Treg depleting drug, right? Which I don't know, I've tried like 5 phase 1s targeting Tregs and had no luck, so. Yes, yes, all of the above. I don't know. I keep opening these trials and not having a lot of luck with Treg depletion. But I mean, I think the idea is absolutely there, right? When we can get better at targeting the microenvironment and getting rid of both the suppressive cells and the cytokines, right? I mean, chemo is just, it's just a blanket, get rid of everything bad. And by the way, get rid of a bunch of good things in the process. But I think we just don't have specific enough agents yet, but it's absolutely on the radar. But I think the other piece of that is also engineering better cells, right? I think we need better effectors to be able to, lower the dose or even eliminate the need for lymphodepletion.
We have a question online from Jay Nuka. Can you please comment on the characterization of TILs in different metastatic sites in the same patient? Is there any benefit of generating the product from multiple sites than from a single site?
Great question. We don't know the answer to that yet. Most patients, especially on the C-144-01 trial, only had one surgical site. As you can imagine, we're not super enthusiastic about doing multiple, sites of surgery for patients. The OBX-115 trial is probably our first ability to really start to answer that. Patients on that trial have the ability to undergo multiple core biopsies, and we are starting to do this in multiple core biopsies from different sites to potentially be able to pool and see if that is better or different than taking from one site. So we don't have the answer to that yet, but we are absolutely thinking about it. David.
The tumor burden has much effect on the responses.
Yeah, absolutely. I mean, we know this for every cancer therapy, right? More than 3 sites of disease, bulky disease, it's going to be harder to treat. I think one of the things, though, that we have seen, there was certainly fear about liver as a, quote unquote, immune protected site. We know that liver is somewhat less responsive to immune checkpoint blockade. I will tell you that, while it is probably slightly less responsive to TILs as well, I've had beautiful responses, including complete responses in the liver. But yes, absolutely, bulky disease is harder to treat. And this is really one of the reasons that I'm really advocating for patients who are eligible and well to get on cell therapy as soon as possible, as soon as they're progressing on PD-1, and not waiting till their 5th, 6th, 7th line of therapy, having really bulky disease and really sick, because yes, I think the chance that it's going to work is low.
Do you think there's a role for our radiation colleagues in helping
Stole
out?
my question.
I'm sorry.
I do. I absolutely do. I think the challenge is just figuring out where, when, how to fit it in, right? Because you don't want to kill the TIL. Right, and we are absolutely using radiation frequently, actually, as bridging therapy right now. I still have some concerns about, and we just need to get data, and we're collecting it, certainly, but it's just such early days. Radiating large sites, and what about count recovery and, immune reconstitution if we radiate large sites, even during bridging, even after the TILs have come out from manufacture. So I think there's a lot of questions to answer there, but absolutely, I think there's a role. I just, I'm trying to figure out how to play Tetris here with all of the pieces. Yeah. For sure.
How have you sequenced it with SRS, or what has been the patient selection? Have they been patients who had too numerous brain metastases for SRS, or they'd otherwise be getting whole brain, or have they already gotten SRS? Then you're doing this.
Yeah, so, standard of care TIL patients, we absolutely will do, SRS to a few lesions. They can demonstrate 4 weeks of stability, and we'll take them straight to TIL. But for the active brain mets trial, those are patients who either, had already had SRS and then popped up new lesions, so you just aren't going to get that window, right? Had too many, as you say, other thoughts. SRS for the brain to me is like a no-brainer for these patients. Like, right, I mean, low toxicity, high yield, like, why would we not do it? And we are pretty routinely. I think the challenge for many of our melanoma patients, particularly in the PD-1 refractory, and most particularly if they've also progressed on BRAF/MEK, is just finding any period of stability where they don't pop up a new brain met, right? SRS is wonderful in the spot that you treat. But, we start playing whack-a-mole with brain metastases, and it's really a challenge.
On trying to relate to vacation for HLA matching and Stanford.
Yeah, it's a hard problem, but yes. And I personally am not working on that one. I am leaving that to much smarter colleagues. But absolutely. And in fact, some of the companies, including Adaptimmune that just approved afami-cel, are working on non-HLA restricted, or at least less HLA restricted. I think there's attempts to do both. This is a huge, scientific issue. It's a huge patient equity issue. We're all aware of it. You know, it's just it's a hard problem because you have to display the antigen, right? But I do think it's an engineering problem. There's smart engineers out there, so.
What would happen if we gave TILs to organ transplant?
Cool. It's a great question because I just was on consult this week asking just that question. Yeah, it's you know, I haven't bit the bullet on it yet. I'm sure it's gonna end up happening one of these days. You know, we'll probably start with the kidney because if you lose the kidney, you have dialysis to fall back on. I think one of the challenges, you know, especially with the kidney transplant, however, is still that you have to give IL-2. And so you're in the, I mean, IL-2, right, is renal toxic, as we all know, but also is renally cleared. And so if you run into renal failure, we've had this, I've had this both on the trials as well as in commercial patients, and you start not being able to clear IL-2 and IL-2 is not really dialyzed off, you can end up in a really bad spot. And so I can't say I've done it yet, but you know, these patients have no alternative treatments for their melanoma right now, and we're inevitably going to start doing it, but we don't have any data yet.
Cutaneous squamous cells and Merkel cells, I mean, they seem like good candidates.
Yes, absolutely. You know, this was something, you know, I've been particularly interested in starting to manufacture our own TILs so that we can start to do that. You know, right now getting a company interested in cutaneous squamous cell. Cutaneous squamous cell is a little bit challenging for a variety of reasons, just like head and neck. Patients are older, they're sicker. It's not a great patient population to do TIL, especially with IL-2. But Merkel it's just such a small disease that getting, companies interested in doing that trial is very challenging.
Great talk.
It's almost 6 a.m. I'm almost awake now. You're at least coming to lunch. Yeah. Also great. Chat. Thank you so much for giving me